That's right.
Still here.
Yep. Oh,
Here, yeah.
wow.
Yeah.
My
Wow,
the
that's
kids just
amazing.
went there. It's just today. Yeah. All right, it's 5 o'clock. Thank you everyone for being here in this wonderful summer evening. I hope you are staying in air-conditioned places. Very grateful today. My name is Chuza Moon. I'm an associate professor at College of Nursing at the University of Iowa as a member of Education Committee at the National Center for Gerontological Nursing Excellence. I'm very honored to have August NHCGNE Fireside Chat. Each chat begins with a brief presentation followed by an informal discussion where you can engage directly with the speakers. We also have a quick survey for us to receive feedback, so I'll put that link in the chat box. Today, Dr. Tom Blodgett will discuss the delirium diagnosis and management simulation used in training nurse practitioner students at Duke University. Dr. Blodgett is an assistant professor at Duke University where he served as both an educator and researcher. His work focuses on developing high-impact clinical research programs aimed at preventing and managing delirium in hospitalized older adults. Tom, do you want to start?
Sure. Thank you for that lovely introduction. So what I'll be talking about is how I was able to merge my area of scholarship, which is delirium prevention, with my educational role teaching nurse practitioner students in our adult gero acute and adult gero primary care programs. So this is the outline that I'll be following. I'll give you a little bit of context of where this simulation activity fits within our curriculum. I'll review some of the learning objectives for our NP students, and I'll give you some nuts and bolts about how the simulation scenario was designed and evaluated, and then provide a few lessons learned so that you don't make the same mistakes I did. So the context of this simulation is that it fits within what we call one of our on-campus intensives or OCIs. So for all of our NP majors, we have, I think, 8 of them now. We bring students on campus for 2 to 3 days of sort of a workshop style skill building and community building experience. And this one fits within my course, which is Advanced Practice Nursing Care of Older Adults, which is required for students in our FNP, Adult Gero Primary, and Adult Gero Acute NP programs. So prior to this course, they will have had their MSN course, so like their scholarly nursing activity, their EBP course, their population health, that sort of general content. They will have had all 3 Ps, and then they will have had one didactic primary care course. So this is actually pretty far along in their plan of study. So the OCI for this course is a 3-day experience. There is 1 day set aside just for the adult gero acute care folks. There is a second day where they are combined with all the primary care folks, and we do a lot of activities together. And then there's the third day, which is just for the FNP and adult gero primary students. This is the general layout of the activities we do for the course while they're on campus. The Tuesday and Thursdays are the day 1 and 3, and they do a lot of the same things. The only real difference, the primary difference, is in the simulation. And we'll get to some of those differences in a minute. But the day that we have them here together, I actually developed an urgent care procedures workshop. So they get to do some fun activities, like everyone loves draining abscesses. So they get to do that. And everybody likes to do, cerumen impaction. So we dig raisins out of model ears and things like that. So they get some experience with that. We do a deep dive into how to do the MOCA, not obviously the full course, but we introduce the idea and then point them to the online training program. And then we do a hologram-based simulation, which some of you know my wife, Nikki Blodgett. She runs our simulation center, and so she has a hologram based simulation experience that students can interact with and in this case, practice some med management for someone with early onset Parkinson's disease. And then they get together at the end where a group of a group of panelists from the Duke Health System, so geriatricians, hospital medicine, palliative care, and then a variety of other folks, population health nurses, case managers, come over and we talk through some difficult patient care transitions from the students' clinical experiences. So a lot of, I think, really great activities, but the ones that we're going to focus on today are the simulations. So, some guiding thoughts as I was developing this scenario is that delirium can occur anywhere. It can occur in a hospital, which is usually where we think about it, but it can also happen in homes, in residential care, on the golf course, right? It can happen anywhere. And the other major thought is that delirium is often under-recognized, especially when we're using our intuition to guide us. So we wanted to make sure that students left with the impression or the knowledge that a standardized assessment tool will help gain some sensitivity. And really focusing and leaning into this key question of, is the patient different today than they were yesterday? Is this a change from their baseline? And so I think when we were able to lean on that, that's where we could connect with students the most. And then also pointing out some areas where delirium management can be fairly general. So general concepts like, we always have to look for a cause. We always have to give person-centered care and avoid certain things that can raise the risk. So those were built into the scenarios that the students had. So our primary care folks really focused on this undifferentiated case where an older adult comes in with visual hallucinations and just isn't acting right. Um, and so they kind of start the ball rolling. They identify this delirium medical emergency. They interact with a family member, and off to the ER the patient goes. And then the acute care students pick up the case the next day in the inpatient setting. So their objectives focus on sort of monitoring the delirium status and managing those underlying causes. And then also collaborating with the inpatient team, nursing staff. A lot of these folks in the NP program are from an inpatient RN role. And so they're kind of used to seeing this from the nursing perspective. So I wanted them to see it, from the NP role and sort of the questions that the nurses might ask and get them to reflect on questions they may have asked. I won't go into too many of the details, and I'm happy to share these with anyone if they're interested. But the scenarios focus on a patient named Robin Smith who lives in an assisted living facility and has dementia. She started developing new onset visual hallucinations involving her mother. And Robin's older adult child, Sam, calls the office and is like, hey, we got to get mom in. So the primary care folks do their simulation in a mock outpatient exam room with an exam table and all the usual primary care clinic type stuff. There's a computer, there's a rolly stool, there's all the usual stuff. Both of these characters are played by standardized patients or actors hired through the School of Medicine on contract with the School of Nursing. So Robin comes in, she's dressed in street clothes, she's talking agitatedly to her mother, who's no longer, who's not really in the room. And then Sam is played by another actor who provides most of the HPI and the other history and has sort of a nice script to follow. And then two NPs each go in and see the patient and sort of try to tease out the HPI and all that good stuff. The props you can see listed here, the tools that I had them practice with for the scenario were the ultra brief cam and the 3D cam in sort of a sequential fashion so they could see how those two tools work together. They're also provided with a clinic note. So this patient went to an urgent care clinic 5 days ago with worsening incontinence, and so they were provided a copy of that note, also given in advance, posted on the learning management system for the course. And then the simulation team mocked up urine odor for the room to sort of heighten the reality of the experience. So all of our scenarios, all of our simulation experiences at Doosan have a standard universal pre-brief. So they go through that for about 10 minutes, then they run the scenario for 20 minutes. and they do a small group debrief within the room. So there are actually 3 of these rooms going on simultaneously, each with their own pair of SPs and their own facilitators. So each room does a small debrief for about 10 minutes afterwards. They get feedback from the SPs and the facilitators, and then they all come together for a large debrief that lasts about 40 minutes, where they really dig into the objectives of the experience. The acute care scenario is very similar. Again, she's come in for the evening. She's Robin has, we've identified the causes. We're trying to fix those. And she got a good night's sleep. So really not doing too bad today. The setting is an inpatient med surg room. So our room is mocked up with an inpatient bed, an IV pole. We moulage an IV in the patient's arm. They're in a gown, that sort of thing. So Robin again is acted by a standardized patient, and the other character is a nurse, who is actually one of our simulation center faculty. Goes in and plays the nurse, and they're given a script and they're wearing scrubs. And this is not someone that the students will have encountered before. So this is a new face, and really plays the role to perfection. You can see the props that are listed here. So they're given a copy of that urgent care note. They're also given a copy of the ER provider note, so they can see what the ER provider thought when they came in. The hospital medicine H&P, so their admitting note, and then they're also given printouts of labs and the MAR, so the student can see what was given and what their labs look like. And it's the same timeline for the acute care folks as for the primary care folks. The SPs are given lots of detailed information about how to act, what to say, what not to say. And I can give you, some general thoughts about how they were to play the role. For the Robin Smith character, we provided the SPs with some sample videos of people with hyperactive delirium so they could get a sense of the speech style, the mannerisms, and those sorts of things. And they're also given some sort of internal thoughts that they can keep running in their mind to, in case they decide to say something, they can spout off with something fairly standard, right? Like, got to go to the airport, that kind of thing. And the facilitators in this scenario were all faculty from the School of Nursing or the School of Medicine. They were volunteers, so they just came to help out, have a good full 8-hour day, although they could sign up for 2-hour blocks if they chose to. And so they were experts in either geriatrics or in simulation-based learning. So one of their responsibilities was to monitor the scenario through a telemonitor. They weren't actually in the room with the student. So they were watching and listening to what was going on. And they had a rubric that they could check things off and take notes if they wanted to. They were provided with lots of information to help them get ready for the scenario. We gave them suggested prompts for the debriefings. So if they were kind of novices to simulation, weren't sure how to ask the questions during debriefing, we had some prompts to get them started. And then I also provided all of them with our PowerPoint lectures from class and transcripts about what the students were expected to know about delirium. I'm not going to go over these except to say that these 2 slides are basically the elements from the rubric or the checklist that facilitators could use to sort of take notes and, oh yeah, they did this, but they forgot to ask about allergies or, what have you. And here's the one for the acute care folks. One thing that I really wanted to hit on in the acute care scenario was decision making around the underlying causes, and which orders to write and which ones to stop. And then also communicating with the nurse, because the nurse is doing the typical thing, which is, I've got to keep them in bed and I've got to give them Haldol if they look angry and those sorts of things. And so I wanted to see how the students were going to react to that. So that was baked into the scenario and into the rubric. So it was something we were sure to talk about. So the evaluation of the scenario, there were 2 parts. One is using a standardized sim effectiveness tool called the SET-M. And that part was done by the simulation center. So Nikki and her shop have those data, and it's for their own sort of internal evaluation of the sim scenario, or sim logistics is more kind of what they get from that. But what I was interested in was this survey that I developed, because there's really nothing about how do you evaluate NP students in sim. Um, it's just a simple, perception type survey about how comfortable did you feel before the scenario in this particular task, and how comfortable did you feel afterwards. There were also some knowledge questions about delirium, just to sort of gauge where they were. And then there were, of course, open-ended fields for unstructured evaluation data. These are a couple of the questions that I asked, and I think there are a couple things I want to point out. First of all, the orange bars are their sort of their answers after the scenario, and the blue were their answers before. So there was a general shift towards feeling more comfortable with using the CAM, with diagnosing whether or not delirium is present, and identifying the underlying causes of delirium. So there's a general trend towards improvement and feeling comfortable with that. And I mean, I know that self-report, like confidence and comfort level, and those are very low level sort of evaluative criteria. Um, but this was sort of what we could measure, given the situation we had. But we also had a lot of nice qualitative data too. And then the primary care students were asked a question about how likely you are to transfer them to the ED. In other words, how likely are you to recognize that this is a medical emergency and you can't just send them home with it? And the vast majority of students were appropriately wanting to send them to the ED. So some of the open-ended feedback, there were, obviously, you can imagine, pluses and minuses. The students really liked the simulation. It was stressful, but they were able to use some critical thinking and develop some confidence. They really liked the hired actors because it felt very real. Um, and the simulation was applicable even to the acute care students, which has sort of been a thorn in the side of these experiences in the past for the course, is that they all felt very primary care focused. But these acute care students liked it as well. And then the comment about having personal feedback right after, it tells me that potentially we need to either add more time or add more intention to the small group feedback right after the sim, because I think that's where the opportunity to give individual feedback is really the strongest. The only area in the open-ended feedback that suggested some opportunities for improvement were, they didn't like having two students in there at once doing this, which is completely understandable. You don't go to a clinic and get asked, seen by two NPs at once, right? It's very unrealistic. And this was honestly done out of more of a logistics and operations standpoint. We didn't have 2 full days to do this. And we also didn't have, you know, 6 rooms to put SPs in. So we had to make some sacrifices. And unfortunately, putting 2 students in a room was what we had to do to make this logistically feasible. Um, so that was a thing that that you're right. That's probably not the best, most realistic setting, but that's a sacrifice we sometimes have to make in simulation. Um, so some lessons learned. Absolutely, any simulation, as you all know, takes a lot of effort and people to coordinate it. Developing a new simulation scenario from start to finish can take up to 40 hours. And this one was no exception. This was a lot of effort, just sort of thinking and consulting and working closely with our Center for Nursing Discovery, which is our simulation center. And also, it took all of our volunteer faculty facilitators. There were 3 rooms going at a time, so that meant I needed 3 facilitators. Some only could be there 2 hours, so it's getting a backup facilitator. And so having lots of people who were available to do this was a huge blessing. being in a position in which we could hire standardized actors instead of, having to sort of just do our best with a limited budget. We were able to hire actors. And then, of course, having engaged learners makes all the difference. The other big lesson I learned early on, the first time I did this a couple of years ago, was that there's a lot of preparation that goes into getting all of the other people up to speed. So coming up with the rubrics so that everyone has a standardized set of expectations in the room, developing scripts for the SPs, making sure that learners have access to mock charts. That took a little while to write, and then doing a dry run with the team, providing those debriefing prompts for novice debriefers, and then making sure that the scenarios and what we expected the students to do fit clearly within their scope of practice as NPs, so that acute care students could clearly see where their role has boundaries, the primary care NP could see where their role has boundaries, and sort of when the handoff can occur safely. So those were some of the lessons that I learned. It's not a perfect experience, but it is a good learning experience. And I think our students really enjoyed their time in the lab. So that is the end of my presentation. So I'm going to open it up to any questions that you might have.
First of all, thank you so much for this informative lesson that you shared with us. Yeah, any questions from the audience?
I have a comment.
Yes,
Yeah,
I can.
Kitty, you can comment.
First of all, Tom, I thought it was an excellent presentation. You covered a lot of material, and it's really an innovative teaching tool. And I just wanted to say that I wouldn't be, well, I think comfortableness is a good thing to measure, because unless you have a psych or gero background, if you're encountering especially a hyperactive type delirious patient for the first time, it can be downright scary.
That's true. Yeah,
And the
that's very
impulse
true.
is to get out of there, or send them away. And so
Yes, yeah.
comfortableness is really a initial important factor before you can really establish rapport and work with the person and even think about what needs to be done logically, because it's the emotional reaction sometimes is wanting to
That,
distance yourself from
that's a good
a
point. I didn't think
crazy
about it
person.
that
Yeah,
way.
yeah, yeah. So
Thank you.
yeah.
Thank you. I
Yes.
have one question. So with the cases, with the actors, what is the like type of scenarios? Are these like unfolding cases that changes over time, or just like actors act and done?
Yeah, so the primary care students sort of see act one, if you will,
Uh-huh.
where the SP and her their son or daughter come in and sort of start the ball rolling and identify, yeah, this person seems to have delirium and we need to get this patient worked up. And then off they go to the ER, right? And so that's end of act one. And the primary care students debrief. The acute
Mm.
care students pick up on their sim day and sort of run that first day in the hospital, a 20-minute snippet of it, sort of basically rounds. Um, and uh, and then that's the end of their day, right? After that 20 minutes. So it's not as though they're sort of skipping ahead or skipping behind within a 20-minute session. It's they act out 20 minutes of it, and that's their snippet.
Yeah, I can see this is a really team effort with a
Mhm.
whole village that you just mentioned. So it's very impressive that all the team members were got together in that 3 day period and
Mhm.
working, and you might be organizing, working behind the scenes. That's amazing. On top of
Um,
designing these.
what's kind of funny is that this past summer, when once you get your volunteer facilitators locked in, you're like, oh, please nobody get sick, please nobody get
Oh
sick.
no.
And
Yes.
of course someone's kid got sick and so had to
Yes.
cancel. And I'm like, oh my God. But I
Mm.
was able to find a colleague to come in and fill
Nice.
in for a couple of hours, which was fantastic because I was already in another room teaching.
Of course, of course.
I want to recognize a couple of my colleagues here who have done some of these OCI experiences, Melanie Bunn and
Mhm.
Letha Joseph.
Oh, nice.
They are some of my fantastic colleagues who've helped, along with Ellie McConnell and, oh boy, Mitch Heflin, Christina Hendricks. A lot of my colleagues have done these scenarios with me, so it's really a great team.
Can I make one other quick comment?
Yeah.
I was really pleased to see that your scenario included somebody with a delirium imposed on an existing dementia, because that is often missed.
Yes.
The behaviors are just attributed to, oh, well, their dementia is getting worse. And it's so critical to identify the underlying causes and treat the delirium. It's probably not going to do anything in terms of the overall trajectory of the dementia, but it will
Yeah.
certainly improve quality of life for both the
Yeah.
staff caregivers, the family, and the person with dementia and delirium. So that was a really good scenario to pick.
Thank you. I tried to pack as much in there as I could without being too overwhelming. Amanda, your question, yes, on-campus intensive. Thanks, Letha. So that's an opportunity for our NP students who are at a distance we even had a couple from Alaska in our last group, came to campus, came to Durham for 3 days for sort of a workshop style skill building experience.
That's so nice. Are you guys doing it some for undergrad education as well, or is it something
Oh,
only for
yes.
NPs currently?
The main users of our simulation center are our pre-licensure students.
Uh-huh.
And I think there are simulation activities happening with our graduate students more now than there used to be. But this is, I don't know if I want to say I guess I'll stop there because I don't know what the other folks are doing within their majors. But for this major, this is the only simulation experience for these learners, the
Oh.
FNP, the adult gero primary care students. The acute care folks have other things, which are
Mm-hmm.
sort of a blend between simulation and skills. So
Mm-hmm.
they do scenarios involving chest tube insertion, and they actually have to put a chest tube in a mannequin, sort of a thing. So, yeah, but it's primarily a center that's used in pre-licensure students.
So some of the sims are going on with the undergrad students, but particularly the delirium. I am following up on
Oh,
Amanda's question.
oh, okay, sorry.
Uh-huh.
Let me look at that question. Just any delirium? Oh, any sims on delirium for undergrad? No, there aren't.
Oh.
But that is an opportunity for us to add in because we just changed our curriculum, our pre-licensure program to a master's entry to practice. And I don't really teach in that program very much, but I know someone who does. Wink, wink. Nod to Nikki. Um, but she co-teaches the Gero course, or occasionally co-teaches the Gero course. And I think that they want to build a simulation experience related to delirium in there, but I don't think they have yet.
Awesome.
This is Amanda. Sorry, I can't show you my face because I'm surrounded by children coming home from school. And you guys would be like, this looks like crazy delirium too. The reason I asked is because I'm a sim coordinator at an undergrad place, and I just thought, man, what a cool design. I love the 2 phases you have for primary care and acute care, but then I was like, oh, this would be so neat. I think there are ways you could take what you've done and then just make it applicable at the undergrad. But what I wanted to tell you, because I totally respect your problem with, there was some negative feedback because they didn't want 2 students in a room at a time. And I feel you there, man, because I'm always battling that. One way that I've gotten around that is to have one of the partners observe. And then they have to take structured observation notes and be a part of leading the debriefing. And there's a lot of research and support for that kind of coming out in the sim world. So
Yes.
sometimes they still get frustrated if they don't get to be the person in the room, but that sometimes is how I've gotten around it too.
We had considered that, and the obstacle really came in with, it was really as basic as where are they going to sit in the facilitator room, because there's really not much room in the ante room area where they watch the scenario, where the facilitator, so they would have to sit with the facilitator and watch the monitor. And so it's just a matter of like putting another stool in there kind of a thing. And I think that that would work better, because most of the learning does happen in debriefing when they're there together anyway. But thank you for that suggestion, Amanda. I appreciate that.
Just to follow up on that, if you don't have a lot of space, if you put a tiny camera somewhere,
Okay.
they can sign in as a Google Meet, and you can
Oh.
you can ensure them that you're not recording, and then they just watch through Google Meet from anywhere.
So we do our video and audio through Learning Space. It's a university, the university mandates that's the
Wow.
technology we
Okay,
use.
so that won't work
But
either. Man,
I know they've thought of everything except how to put two people in a room. But thank you, Amanda. I think we'll keep working on that problem and try to get some more individualized education in there.
Wonderful. Thank you, Tom, and thank you for all the people who attended this fireside chat. This was a really wonderful discussion. And Tom, would you mind taking any questions or any feedback from the audience if they have anything?
Of course, please
Yeah.
send me your questions, comments. I'll put my email in the chat.
Yeah, and we have scheduled our next fireside chat will be presented by Lisa Wise. So please stay tuned for that. Otherwise, everyone have a nice, wonderful evening, and I'll see you in next month. Bye
Bye,
bye.
everybody. Bye, Kitty. It was good seeing
Bye.
you.
Seeing you.
Bye, Lisa. Hi, bye, Melanie. Bye, Kathleen.
Bye.